I'll do a quick intro on Dr. Meyers. So I'm surprised that I have not heard about Dr. Meyers before because his CV is pretty impressive. He helps EMS providers up their game and become better clinicians through a lot of education and mentoring. He has a total of 33 years in emergency services as an EMT, paramedic, EMS physician, and EMS medical director. He trained at the University at Buffalo in emergency medicine and EMS and has worked in academic and community emergency department settings. He's been active as an EMS medical director for several services during his career. He has a dynamic style and his expertise in making the complex concepts simple. He currently works clinically in the emergency medicine residency program at Southeastern Regional Medical Center, Lumberton, North Carolina, and is active as an EMS physician and educator nationally.
Good afternoon. Thanks, Floyd.
All right, you're welcome. Thank you.
Let me share the screen here. All right, is that coming through okay? Am I sounding okay?
Yeah, it's coming through. We've got a full screen and you sound very clear.
Excellent, excellent. Thank you very much for the invitation to join you guys today. Thank you, everybody who's participating in this conference. This is an amazing event put together virtually and free. In a time where we're all, I think, overstressed and have a lack of sleep and self-care just with everything that's going on. I wanted to talk a little bit about concussion, and I want you guys to get a couple things out of this talk. One was kind of why do concussions occur, a little bit about the pathophysiology, but then also how do we pick up on some of the subtle indications of a concussion that may make the difference between whether you're going to transport this person or kind of urge them to get care immediately or in the short term. Recognizing that some patients do not want to use emergency transport versus those who may be able to follow up with their primary care or other means of accessing medical care. So how important of a problem are concussions? Well, it's estimated, and this is from 2018, about 1.6 to 3.8 million concussions occur annually in the US. When we look at sports-related concussions, can you guess how many, or what can you guess the sport that generates the most concussions? Well, as you can imagine, the one with a lot of contact is football, generating about 300,000 concussions annually. The next one is hockey, as you can imagine, boxing or MMA, and then soccer are some of the other big ones. Interestingly, when we look at high school sports, and again, we're limiting ourselves to sports at this moment, but we're the number 2 and number 3 sports that generate concussions are women's soccer and women's lacrosse, with men's football being the most common, just like in adults. It's estimated that about 50% of these concussions aren't reported, which is why the 1.6 to 3.8 million is kind of a huge disparity, right? That's not a very accurate number, but it's estimated that about 50% are not reported. If we want to look maybe a little bit better idea of the prevalence of concussions, this is a study out of Ontario province. And again, political discussion aside, this is one of the advantages of having a single payer healthcare system where we can get into that database and look and see how many people are diagnosed with a concussion in a year. It's a very simple question to answer when you're not dealing with multiple sources. Well, for the year, and I believe this was 2017, it may have been 2016, approximately 1.2% of the population, which turned out to be roughly about 150,000 people in the Ontario province, were diagnosed with concussions that year. That's a huge amount, especially if we extrapolate that out, let's say, to the US population. That was about 328 billion in or 3.28 billion in 2018. That's a lot of people, and this is all comers. This isn't just sports-related concussion. This is the people who are assaulted and develop a concussion, the people that fall down and are diagnosed with a concussion, the people that are in traffic accidents. So it's all comers, not just sports-related concussion. Another interesting tidbit is in a study of high schoolers. Now, again, you're thinking the high schoolers, they're invincible. Nothing's going to stop them. When we look at self-reported recovery in patients who've been diagnosed with a concussion, about 40% of high school students with sports-related concussions who said, "Hey, I'm all better. I don't have any deficits anymore. I'm back. I can go play again, coach." 40% of them still had neuropsych deficits. So there's a lot of deficits that we're missing, and this unfortunately ends up setting those players up, setting those patients up, setting those people up for long-term injury, disability, and dysfunction when they end up sustaining another head injury. Some of the long-term effects of concussions include things like mood disorders. When we look at depression and suicide, the rate of new depression a year after a concussion, or a year out from patients who've been diagnosed with a concussion, is about 30 to 40% higher than patients of the same age group who were not diagnosed with a concussion. So just having a concussion ends up increasing that risk of depression, increasing that risk of suicide. And that's just with one concussion. That's not talking about repeated injuries. How many people do we know who've been pretty active with sports? I've had multiple concussions. Some of them may not have even recognized. Then especially when we focus on our students in middle school, later middle school, we're starting to get into some contact sports, or like me, who was hitting the head with a bat when I was playing Little League in third or fourth grade. We look at learning disabilities, attention disorders, chronic migraines, memory deficits, all these things that can have long-term debilitation. So what's the definition of a concussion? We need a definition. This is a definition from the American Medical Society for Sports Medicine. This was published in 2019. And the important part of this definition is a traumatically induced transient disturbance of brain function. Now, they put it on the subset of mild traumatic brain injury. We can debate that a little bit, because if we extrapolate this out and look at multiple concussions, if we look at long-term issues from concussion, it's not a benign disease that we all think. But the gist is that it's traumatically induced transient disturbance of brain function. I like the WHO definition of concussion only because it's very practical. I'm an ER doc. I like to keep things simple. ER doc and paramedic like to keep things simple. So we're looking at symptoms on the left in blue: confusion, disorientation, loss of consciousness less than 30 minutes, post-traumatic amnesia. So whether it's retrograde before the event, anterograde after the event, of less than 24 hours, or transient neuroabnormalities. And we're talking not about those transient stinger type injuries where the patient had numbness in their hand and it's gone away, or pain radiating down their extremity and gone away that may be tied more into a spinal injury. But I'm talking about they were off balance, they were confused, they were irritable, transient, and they go away. And then the other half of that is on an assessment or objective level. Their GCS is between 13 and 15 at about 30 minutes, or at the ER, whichever comes first. So we're talking about some symptomatology with a minor deficit. Let's talk a little bit about anatomy and physiology. This is our brain. This is a fresh frozen section of brain that we sectioned in medical school for teaching purposes. The big take-home thing that I want you to see here or understand here is the brain is made up of a very gelatinous material. We're all used to, and I've got a couple pictures illustrating another diagram in a later slide. We're all used to seeing the brain when it's fixed with formaldehyde, and it looks a lot different. You can imagine that this gelatinous brain, this jello brain, this jello mold of tissue does not deform very well, kind of over deforms when we apply forces to that area. We've got the cerebrum, or the upper part of the brain, that's responsible for movement, speech, hearing, sight, and executive function. We've got the cerebellum down here posteriorly and inferiorly, that's responsible mainly for balance. And then we've got our brainstem, which is responsible for cranial nerve function, autonomic function, that moves seamlessly down into the spinal cord, surrounded by this thick layer of bone, or the skull, to protect the brain, and then divided by two very thick fibrous sections of tissue, the falx, dividing left and right, and the tatorium, which you cannot see in this picture, that divides the upper and lower. So that's just kind of the basic gross anatomy. Kind of cool, again, take-home message: the brain is jello. When we get down to the microscopic level, these are our neurons. We take a look at the cell body and nucleus. This is the computer part of the brain, of the neuron, takes the inputs from these dendrites that reach out to the other nerve cells and form that neural network, take those messages, figures out what we need to do with those messages, and then either keeps it or passes it along. If we're going to pass it along, we send that message down the axon to the terminal, where we release neurotransmitters on to the next node in the chain. We've all heard of the blood-brain barrier. This is a very important piece of anatomy, where certain brain cells, the astrocytes, form these processes that surround the capillary. So here's the capillary here. Hopefully you can see that. I'm using my my arrow on the screen there. If not, it's right there. Anyway, the astrocytes form this coating on the capillaries with a very small gap that allows nutrients, oxygen, waste products to go through. Some medications will not penetrate the blood-brain barrier. Some viral particles, some bacteria will not penetrate the blood-brain barrier as long as it stays intact. If it gets disrupted by an inflammatory process, for example, sepsis, for example, traumatic brain injury, then all bets are off. We set off an inflammatory cascade in the brain that can cause some long-lasting damage that leads to things like chronic traumatic encephalopathy, which has been highlighted over the last few years with some of our football players and hockey players who've had some significant mental health issues from their repeated traumatic brain injuries. So what forces cause concussions? We can kind of divide these into two different bins. One is our direct contact force, and the other are inertial forces. So when we think about direct forces on the brain that cause injury, we're talking about where the force is directly applied to the skull, face, brain, eyes, back of the head, anything to do with the head. Whether we're talking about sports, or whether we're talking about someone who falls down the steps and smacks their forehead on the concrete, or whether we're talking about someone who is in a car accident and smacks their temple on the B post of the car. Inertial forces, on the other hand, are more of acceleration, deceleration forces. This is where we have a sudden acceleration and then stopping. This causes shear forces to be applied to the brain. Those shear forces, and here, this is the fixed version of the brain that I mentioned earlier when we were talking about anatomy. But these inertial forces can take the place of linear forces that move along the axis of the brain, either longitudinally or transversely. So a transverse section, if this is my brain, or can be rotational. So, for example, the boxer who gets a punch to the side, causing their head to turn, that's a rotational force. Now, the linear inertial forces are better sustained by the brain tissue. It can handle those forces a little bit better than the rotational forces. Those rotational forces, as you can imagine, can cause significant shearing of the neurons. Trying to use my hands here to illustrate that. Can cause some significant shear forces in the neurons that will disrupt the neurons and cause the neurotransmitters to leak out, which depolarizes other neurons, as well as cause that inflammatory process that we talked about before if the blood-brain barrier is disrupted. Now, what are the clinical effects? Let's kind of come out of pathophysiology. What are we seeing as EMS providers when we get to the scene, when we get on the sidelines? some of the clinical effects that we'll see from concussion fall into these 4 categories. When we look at mood disturbances, sleep disturbances are extremely common in patients who've been diagnosed with a concussion, whether we're talking about difficulty in falling asleep, or whether we're talking about difficulty in staying asleep, or kind of the third possibility is just disruption of REM sleep, where the patient is able to get to sleep, but they're not able to stay into that REM sleep that's restorative and allows the brain to not only process information from the prior day, but also repair itself. When we look at depression and anxiety, as mentioned earlier, depression and anxiety can either develop in patients who do not have a prior history of depression and anxiety just from the one concussion, or may unmask subclinical depression, subclinical anxiety, or both that, again, may have been present before the injury. When we look at things like functional MRIs and other means of getting down microscopically, we do see some changes that are similar to what occurs in patients who have sustained a non-traumatic PTSD. Those changes occur with concussion as well. So again, linking some of these mental health conditions with the traumatic brain injury. When we talk about headache, and again, we get down at the microscopic level and look at the what happens at the microscopic level, a lot of the pathophysiology and a lot of the common endpoints are very similar to the pathophysiology of migraine, very frighteningly similar, which it kind of accounts for why the patients who do sustain a concussion end up developing headaches that have some very migraine type qualities. It may be unilateral, maybe bilateral, maybe frontal or occipital, but especially the light sensitivity, the sound sensitivity, the chronic nausea, the vomiting. These are all features that can be very, very debilitating. When we talk about frontal lobe dysfunction, we're talking more about those executive functions, attention, memory, personality changes that will sometimes occur with brain injury. If we're looking at patients who are in an educational setting, whether they're talking about middle school, high school, college, or even adult learners, this can affect the ability to maintain attention during lectures. This may make it difficult to focus while doing fine motor tasks. Imagine if you've had a concussion and now you're trying to start an IV, which may disrupt your ability to start that IV properly. Irritability, that calm, cool, and collected person that nothing seems to faze now is irritable, and they're quote unquote flying off the handle for no reason. Memory processing, taking information from short-term memory and putting it into long-term memory so that we can use it is affected by concussion as well. So think of making a grocery list and then doing like I do sometimes and leaving it at home and getting to the grocery store 5 minutes later and not remembering what you had on your list because what you had on your list didn't get processed into long-term memory. So imagine doing that or having that happen every day. And then finally, when we look at the vestibular or ocular issues that will occur with concussion, we're talking about things like dizziness and vertigo, that processing in the cerebellum where we are able to maintain our balance or keep our balance. Think of our elderly patients who fall and hit their head and develop a concussion and have a balance issue. Now they're at more risk for that second or third fall and either orthopedic injuries or additional brain injuries. Diplopia or double vision and blurred vision, so visual changes that can affect your ability, again, to impair your balance, affect your ability to concentrate. Imagine if you have this chronic blurry vision from your concussion, how easy is it going to be able to read the words on the book or on the computer screen, especially computer screens, as you're trying to study. So let's talk about, I termed this on-field assessment, but this, we can extrapolate this to our general EMS call, your car accident, our assault, our fall. But let's talk about our assessment. As with every patient, we need to make sure that we take care of any critical life-threatening issues, airway, breathing, circulation, have a quick disability assessment, expose as necessary. And then, yes, I mentioned it, spinal motion restriction if needed in the patients where it's needed and indicated. Not everybody, please don't do that. That's a different talk. Anyway, next topic, imaging indications. So as an emergency physician, what I'm thinking of when I'm looking at, do I need to image or do a CAT scan on this patient? Because that's what I have as available 24/7 and can perform very quickly. I'm looking for things like focal neurodeficits. So is there an abnormal strength on one extremity or one side of the body? Is there a sensation difference left to right? Is there post-traumatic amnesia, again, retrograde before the incident where they don't remember what happened for several hours before the incident? Or are they perseverating and asking the same question multiple times because they're not processing the information that we're given? They're forgetting that piece of information, the post-traumatic or anterograde amnesia. Altered mental status, where maybe they're alert, but they're either not quite oriented or they're not quite processing what we're telling the patient. Persistent vomiting. Now, some vomiting, one or two episodes is normal after a minor head injury. However, that persistent vomiting is usually very concerning for intracranial hemorrhage. Persistent headache, also concerning for intracranial hemorrhage. Now, as we saw on the fresh frozen slide, there's not a lot of room. The skull is a pretty immobile box. So if we develop any kind of swelling, we're going to have issues. GCS of less than 15 and seizures. Those are all things where I'm thinking, yep, patient needs to be imaged. Loss of consciousness is a little controversial because some patients have a brief loss of consciousness or maybe questionable loss of consciousness. They're completely normal when I see them in the emergency department, half an hour to an hour, hour and a half later. And so in certain patients, I may just watch them and reevaluate them. Patients who are over 60, because as we get older, our brains do shrink in mass. This puts some stress on the bridging veins that go from the dura, where the vascular feeders of the brain meets the brain tissue, and therefore any kind of forces applied to the brain can cause bleeding, cause your subdural hemorrhages. Drugs and alcohol can both impair your ability to get a good neurologic examination, but especially with patients who use alcohol chronically, that is an anticoagulant in itself and can cause bleeding disorders. Coagulopathy, it seems like everybody and their brother and sister these days are on some sort of anticoagulant other than aspirin. And whether we're talking about Pradaxa, Eliquis, warfarin, Coumadin, rat poison, doesn't really matter for a variety of reasons, whether they've had a past stroke, they got cardiac stents, but it seems like almost all of our patients are on some sort of anticoagulant to make them breathe. They bonk their head, they're at a higher risk of intracranial hemorrhage. So those patients end up getting imaged. And then sometimes with patients who have cervical spine-ish pain, and I've got a moderate to high suspicion that there's a cervical spine injury, I may end up imaging their head as well, because if there's enough energy to disrupt their cervical spine, there's probably enough to cause some level of injury to their brain. Now, why is this important? As an EMS provider, you're going, Doc, I don't have a CT scanner in my ambulance. At least most of you are saying that, unless you're at a couple of places that are doing the stroke buses. But anyway, that being aside, why is this important? Well, we all encounter those patients who have minor injuries who want to sign off. They don't want to go by EMS. They want to go to the hospital. They may not want to go to the hospital at all. They may say, I'm just going to go home and rest. They may say, I'm going to go see my primary care doctor tomorrow. How many of us can get in to see our primary care doctor the next day? I love mine, but I ain't getting to see him the next day. How many of us can do that? This allows you to provide some kind of a higher level of informed consent by saying, hey, you've got these subtle issues here. the doc at the ER may want to do a CAT scan on your brain to make sure that you don't have bleeding on your brain. I know you're feeling all right now, but here's these things that are concerning. Hey, I got an ambulance right here. Why don't you come with us? We'll get you in to see the doc. Anyway, let's talk about concussion assessment. So we're talking about the patient who has perhaps a more minor injury. They don't have any of the obvious signs that, hey, we're going to be transporting this patient emergently, or that obvious patient that obviously needs transport for some reason. But we're talking about the more subtle patient. How are we going to assess assess them for a concussion? Again, as part of a complete neurologic examination, we're going to look at alertness, memory and attention, vestibular function, and ocular function. Some of the things that give you a clue that the patient has had a concussion, the subtle things that the patient has had a concussion, or if they come off the field, or they present when you approach them as confused. They give you a history that they felt dazed after they struck their head. They're feeling a little mentally foggy. You know, they're answering the questions properly. They're alert. They're oriented, but they just feel a little foggy. Maybe they're a little slow to respond. That patient is irritable. Why are you asking me these questions? The first responder already asked me these questions. You know, what, can't you guys get your story straight? You know, that kind of irritability that seems out of place. Loss of consciousness is kind of controversial. There's a lot of patients that I ask, hey, did you black out? Did you lose consciousness? And I said, no, doc, I didn't. But then you ask their family, you ask the other players, you ask their coach, you ask other bystanders, and oh yeah, they were out. They were completely out. So obviously they're patients receiving some input because they think that they were awake, but they've had a loss of consciousness. If you're watching the game at the sideline, and you see a player that's slow to get up after a hit, slow to get up after a tackle, there was a collision on the field and they're slow to get up, those are the ones that patients or players that really should be pulled over the sideline and have a detailed assessment to make sure that we're not missing a subtle concussion. And then the lights on, nobody home, blink, stare. Those are patients that likely had a concussion. This standardized assessment of concussion is something that we'll see the athletic trainers and the coaches use. Very well versed. It's a very validated scale, typically performed by the coach or athletic trainer or the team doc before the season starts to get a baseline, and then after every hit, and then followed during recovery to make sure that the player gets back to baseline. I'm not going to go through this. I can send a link, a reference to it if you email me afterwards, or email through Floyd afterwards. But let's talk about some things a little bit more with our EMS purview. You may on the field ask or see the coach or hear the coach ask these questions, Maddock's questions, which are very sport specific and specific to that player and that team, which were found to be a lot more sensitive at picking up concussion than the typical orientation questions. A lot of people, we get the sense, we EMS providers, physicians, nurses, nurse practitioners, PAs get the sense that there's something not quite right. They're not quite there, but they know where they are. They know what day. They know who the president is. They know about what time it is, at least day or night. They know the month. So they're pretty oriented, but they're not quite right. These questions are a little bit more specific. Some of the physical exam things that you and I can do to try to pick up on the subtle issues of concussion focus on the vestibular ocular deficits that occur with concussion. Why? Because the cerebellum is a little bit more vulnerable to concussion. If it's safe to stand the patient up, again, this is where we've assessed them. They're neurologically intact. We've gone through our spinal motion restriction. All right, I'm going to say it, C-spine clearance protocol, just to get it out there. I'm not as politically correct as some other speakers. Anyway, but if it's okay to stand the patient up, we can check tandem gait. So ask the player to go on, let's say on the baseline or on some other line on the field and walk heel to toe. With our high schoolers in college and adults, we can ask them to go backwards too if there seems to be a little bit of a deficit, or to add some more sensitivity. Try it at home, see if you can do it. The finger to nose testing, is where in this picture, or as in this picture, we've asked the patient to put their arms out to the side, and then we ask them to touch their nose with their eyes closed, and they should be able to do that. Thankfully, mine is intact. Otherwise, someone will call a stroke alert on me. Or we can do a finger to nose where I hold up my finger and I ask the patient to go back and forth like this. So that's the finger to nose. That tests for ataxia. Both of these test for ataxia. When we look at extraocular movements, this should be part of our normal neurologic examination. So left, right, up, down, and then the obliques. Is that full with excursion? Does the patient start to develop any nystagmus or that flitting of the eyes when they look in one direction? Do they kind of have to close their eyes, looking like it makes them appear dizzy or nauseous? And then the near accommodation, for those of us who don't need to wear reading glasses, we shouldn't develop double vision until we're about 2.5 inches away. Shouldn't develop blurriness until we're about 6 inches away. For me, that's a lot further because I wear reading glasses. Ocular response. The saccade movement is having the patient sit or stand in front of you, putting your fingers out at 45-degree angle. Have them start by staring at your nose, and then ask them left or right. I want you to look. I'm going to move these in a little bit. Look quickly left or right. So look quickly left or right. I don't know if you can see on the camera, if my camera has a good enough resolution, but the eyes should move very quickly and very solidly to that finger. If you get a situation where the eyes kind of move over and overshoot and come back, that's an indication that they've got some issues and likely they've had a minor concussion. Vestibular ocular reflex, if we ask the patient to focus on a set point with their eyes and then turn their head, they should maintain focus when they turn to the left and to the right. If when they turn to the left or right, their eyes deviate and then switch back, again, I don't know if the resolution on my camera is good enough to see, but if they, as is depicted in the picture, can't keep their eyes on that point and they flip back, then that's an indication of a dysfunction and they've had a concussion. So there are some tests to add to your neurologic examination to get those subtle concussions that we may miss if we do our normal examination. And again, these are the patients that really need to be seen, need to be pulled from play, and need to be seen. So let's take the last minute or two to talk about return to play. Return to play situations. So pretty much universally, if there's a suspicion that a player has had a concussion, then there's no same-day return to play. They need to be pulled. They need to be assessed a lot more thoroughly, and they need to be cleared to return to play either by the emergency department, their primary care provider, or a sports medicine provider. When we look at the graded return to play, return to school protocols, you notice a very similar concept, that we're going from no activity, which means no exercise, no screen play, no phones, no texting, no videos, no TV, no computer, or at least minimize those the electronic devices, on a graded response on up to where, provided there's periods of symptom-free, the patient's symptom-free, where they can graded return to longer and longer times back to their full activity. Now, a recent study from about 3 or 4 years ago out of the University of Buffalo suggested that including light exercise early on, so even in this time period where we traditionally said no activity, but including some light exercise, so light walking, very slow walking on the treadmill, let's say, no weightlifting or anything like that, but just that kind of light activity will help speed up the recovery process. And what's thought is glucose regulation in the brain becomes dysfunctional after a concussion. And what's thought is that light aerobic exercise, that walking and stuff like that, kind of helps allow that to reset. So these are the graded return to play, return to school protocols. So that's what I have for today. I hope you found this helpful. Again, the two things that I wanted you to get out of this was identifying those subtle concussions and understanding a little bit about how concussions are very disruptive and the long-lasting effects of concussions. Here's my contact information. Please feel free to connect with me on social media, email. But I'll stay in the. I know I went over a little bit, and I apologize, but I'll stay on for a while in the Q&A to answer questions. But thank you very much for listening, and enjoy the rest of the conference.
Thank you, Dr. Myers. Very informative.